Hi, I'm Dr. Brian Koffman, a family doctor and a CLL patient myself, co-founder, the chief medical officer, and the executive vice president of the nonprofit CLL Society. Dr. Seymour, can you introduce yourself, please?
Hi, Brian. Hi, people watching. My name's John Seymour. I'm the director of the Department of Hematology here in Melbourne, Australia at the Peter McCallum Cancer Center in the Royal Melbourne Hospital, and have been doing a bit of work in CLL for a while.
Well, Dr. Seymour, I think you're being a little modest. You've done some really amazing breakthrough work in CLL, and we're going to touch on some of the drugs that have really revolutionized the care of CLL in the last several years. And those are these Bruton tyrosine kinase or BTK inhibitors. And right now in CLL, there are two that are widely used that are approved, Ibrutinib and Acalabrutinib. And you presented some important data at the American Society of Hematology's meeting, updating what we know, comparing those head to head. This is gutsy because this is comparing, two really great drugs against each other. So tell us why you were doing this, what the hopes were, and what you found out.
Thanks, Brian. I think that's one of the important headline take-homes here is that these are both very effective, very good drugs for CLL. And we, our patients and the field is fortunate that we have these choices. Nevertheless, we always want to improve, refine, and do better. So there were two aims with this study, and this was the Elevate-RR study. So a head-to-head randomized comparison, non-blinded, of twice-daily Acalabrutinib versus once-daily Ibrutinib. Now, the primary endpoint was progression-free survival, independently assessed, and these drugs were equivalent. So in terms of
now, this population was a relapsed refractory population, yes. Is that correct? Yeah.
Yes, correct. At least one prior therapy. When we designed it, somewhat enriched for what we thought was adverse biologic features. So that was deletion 17p or deletion 11q. Now, as it turns out, del 11q is not particularly adverse with BTK treatment, but we weren't fully aware of that when we designed it. So relapsed refractory and enriched for deletion 17p, but not exclusively so.
And so this was a comparison of these two drugs in relapsed refractory. So patients probably at this time, their frontline therapy had probably been chemoimmunotherapy, I think in most cases. Correct. That Correct. Might be a different circumstance these days. So what did you find when you compared these drugs? This study has been going on for a long time now.
Yeah, so our median time on drug is over 3 years. And as I said, the progression-free survival equivalent, so in terms of bottom line, duration of control of your CLL will be similar to identical with either arm. So we then looked around important issues around tolerance and impact of toxicity and patient quality of life. Because one of the issues, and I've spoken and published on this over quite a while, is one of the drawbacks of the BTK inhibitors is the need for continuous therapy until progression or intolerance. And so we need to make that as safe and as well tolerated and as the least intrusive on patients' quality of life as we can. So we looked at that side effect burden, that toxicity burden across these two agents. And there were broadly two areas. I'd put them into the inconvenient and the potentially serious toxicities. So of the potentially serious, and these are the cardiovascular, so around irregular heartbeat, what we call arrhythmias, predominantly atrial fibrillation, and high blood pressure, hypertension, which is manageable, but is emerging as a predictor of later untoward cardiac events. So it's desirable, even though it's manageable, it's desirable in my mind to minimize the likelihood of hypertension. And in both of those domains, the Acalabrutinib, Calquence, was less troublesome in terms of a lower risk of those adverse events than Ibrutinib. So, for example, atrial fibrillation, 3.8% versus 1.3%. And hypertension, 15% versus 4%. So lower risk of these potentially serious in the longer term with acalabrutinib. So those rates that I mentioned are adjusted for the duration of exposure. We balanced out how long a patient is on drug and what is the likelihood per 100 patient months of exposure of having those events. And those numbers that I mentioned are those rates, rather than the percentages. So, on average, over 100 months of treatment, 3.8 of those months would be spent with atrial fibrillation as opposed to 1.3, and 15 versus 4.1 with the hypertension. So it adjusts for how long are you on drug, how likely are you to have these adverse events present. So in general, those events were about 2 to 4 times more burdensome, more present with the ibrutinib. And that was similar regardless of your age, prior treatment, previous hypertension, etc. So we couldn't find any patient subsets where that difference appeared to not be shown. The second element was what I refer to, and perhaps easy for me, not being the patient, as inconvenient or troublesome, but not potentially as serious side effects, such as diarrhea, arthralgia, the bleeding tendency, muscle spasms, those sorts of unpleasant, but not usually side effects that would lead people to need to cease treatment. And they were generally 1.5 to as high as 13-fold higher, accounting for that, how long patients were on drug with ibrutinib compared to acalabrutinib. Conversely, there were only 2 adverse events, headache and cough, that was somewhat higher with acalabrutinib than ibrutinib, and they were between 1.1 and 1.6 times more likely. And we know that the headache is that transient phenomena associated with the first 2 to 6 weeks of initiating acalabrutinib, and to be able to reassure patients that it typically is manageable and then settles once there's a degree of tolerance built up. And one of the examples that I think shows the impact of measuring in this way, by looking at the total time with an adverse event rather than purely have you had that event, yes versus no, is around the muscle cramps or the back pain, where purely asking the question, did you get it or not, that was a 6% rate with acalabrutinib and a 13% rate with ibrutinib. Twofold, not a massive difference. Whereas when you factored in how long did you actually have those symptoms present, it was actually 13-fold higher with ibrutinib than acalabrutinib. So I think that illustrates the power of this analysis, where we ask both how persistent is the side effect, as well as simply, did you have it, yes or no?
Very interesting, and I think very informative. I do have to ask a couple questions. At the beginning of the BTK inhibitors, there was concerns about serious bleeding, and you mentioned bleeding as an annoying problem, but for a very small number of patients, it's a catastrophic problem. Was that something that came up in this study?
We absolutely looked at it. There was no difference in the likelihood of major bleeding events between the 2 drugs, acalabrutinib and ibrutinib. There was a slightly higher prevalence of the minor bleeding events, the skin bruising, tendency to bruise with minor trauma with ibrutinib than acalabrutinib.
Did this translate into people discontinuing therapy? I don't know if your study was set up to look at that, but drugs don't work unless you take them, as the Surgeon General Everett Koop once said, so a lot of people stop the BTKs because they can't tolerate them rather than they're no longer effective. Was this a significant issue that you were able to analyze?
We did look at that, and we need to remember that a clinical trial is very rigorously controlled, highly selected patient group. And Anthony Mato, have to give him credit, has done a lot of work looking at what some of the real world impacts are, that the discontinuation rates tend to be higher out in the wild, so to speak, than in the confines of a clinical trial. Nevertheless, the rate was lower with acalabrutinib, so 14.7% of patients discontinued acalabrutinib due to an adverse event, compared to 21.3% with ibrutinib. So roughly a relatively 50% increase with ibrutinib.
Very important work. Any final thoughts or anything you want to get across to patients about this research?
Thanks, Brian. I think as you highlighted at the very beginning, we have a number of very effective drugs. The BTK agents are very good at controlling CLL in the medium to long term. And depending on individual patient profile, both of these are very active, very reasonable choices. Putting aside the issues of twice daily versus once daily dosing that can be burdensome for some patients, acalabrutinib overall has a less burdensome side effect profile, both in the cardiovascular domain, as well as the inconvenient and unpleasant side effects, the diarrhea, the muscle aches, the arthralgia issues. So our patients have a choice, and the relative issues of once daily convenience versus a slightly cleaner side effect profile, patients have the ability to pursue their preferred treatment.
Dr. Seymour, this is such important research. I'm glad and this is not just yours, this is a global effort, this study all over the world. Thank you so much for what you're doing, and the CLL community is very appreciative. Thanks so much.
Thank you, Brian. Thank you for your work.